Well, good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. And it gives me great pleasure to welcome firstly Dr. Lutawa Omar, and she is the manager at Bayer, who's based at, as I understand, in Nairobi, in Kenya. And of course, we're going to have a presentation by Dr. Julie Kluge. I've been over here a few minutes waiting for people to come in, and I must say I've had a wonderful chat to Dr. Lutawa Omar about my time I spent in Nairobi. And I just must, I've told a lot of my stories, but I remember one of the things is I went to a hotel over there and they said, what would you like to drink? I said, I'll have a beer. And they said, what beer would you drink? I said, well, what do the people here drink? And they said, they drink Kessel beer. So I said, all right, bring me a Kessel. So, of course, what does he bring, do you think? A Castle Lager, but they call it Kessel beer. Now, Lutawa, I'm going to start by saying a great big thank you to Bayer, and we're going to start then just before I introduce Dr. Julie Kluge. We're going to have a Corin play a video from Bayer titled Women's Health is in Bayer's DNA. Thank you, Corin.
So we'll have Dr. Omar do the just introduction of Bayer just before the video.
Good afternoon, everyone. Thank you so much for allowing us to partner with the Pelvic Floor Foundation of South Africa this evening. In this webinar, we are very excited. This is our first time partnering with you, and we look forward to many more partnerships. My name is Dr. Lutawa Omar. I'm the medical advisor at Bayer for Women's Health, Ophthalmology, and Oncology. Women's health is in Bayer's DNA. And we are excited that we are able to talk about women's health issues today. And I will allow Karen to play the video that talks about our commitment as Bayer to women's health before we continue with the program. Thank you.
And thank you, Lutawa. It's wonderful to have you.
Thank you very much.
Let me just make sure we've got sound.
Everyone
can hear?
Yeah, we can hear. Thank you. Thank you very much indeed, Corin.
And so are her health needs. Women's health is in Bayer's DNA. For 1 century, Bayer stands for innovation in women's health. The launch of the first oral contraceptive in the 1960s had a massive impact on women's health, relationships, family, career, and empowerment. We are supporting women throughout various stages of their lives, from puberty to motherhood to menopause. Today, we are offering a widespread portfolio, including short and long-acting birth control methods, as well as therapies for management of menopause and gynecological conditions. We are a partner for women supporting education programs and rights-based family planning for more than 50 years in over 130 countries. By 2030, we are committed to providing 100 million women in low and middle income countries with access to modern contraception, investing over 400 million euros in expanding production capabilities alone. We continue to focus on innovative options in women's health, providing science, innovative solutions, and education to support individual health needs of women. Our efforts are now on providing new treatment options for conditions with a high unmet medical need, for example, menopause. Every woman is different, and so are her health needs. Women's health is in Bayer's DNA.
Thank you very much indeed. It's a wonderful
lovely video. Oh,
yeah, thanks so much. And I'm hoping that in future, Dr. Lutawa Omar from Bayer, we will be able to partner. You said we would. And I'm hoping that it's my sincere belief and hope and dream that we will be able to have Bayer with us in the future. Just remember that next week and the week afterwards is holidays. Next week is the varsity and school holidays. So there's no webinar for 2 weeks. The following one, of course, is FIGO in Paris. And the new FIGO, did you know that the new FIGO chairperson comes from Nairobi? Do you know that? Did you know that, Dr. Lutawa?
Dr.
You know her.
Ann Kihara, and she's amazing.
Fantastic.
You will love her
And
people.
yeah, she's from Nairobi.
Yes.
Anyway, so without further waste of time, we're going to have Professor Stephen Jeffrey joining us. And my name is Peter de Jong. I see you've put me as he, him. And I'm going to introduce Dr. Julie Kluger, and she is an obstetrician and gynecological specialist. Dr. Kluger specializes at the moment working at Paarl Hospital. She worked with the Royal College on a program to educate midwives and doctors in postpartum family planning from 2015 to 2018. This is a big focus of the Royal College. And she's headed the Tygerberg Family Planning Clinic from 2011 all the way through to 2019. So there can be no better person qualified to speak about family planning than, in fact, Dr. Judy Kluger. And she's going to be dissecting the topic this afternoon, a case study-based talk on intrauterine contraception. Dr. Judy Kluger, we've heard you before, and it gives me great pleasure to hear and listen to what you're going to be presenting this afternoon. Dr. Judy Kluger.
Okay, thank you. I am very honored that you've invited me again. Let me, I have got 4 cases to present. So you have to just give me a bit of time to figure out what to do now.
You go to slideshow, click on slideshow.
Yes.
Yes,
Oh,
there we go.
Okay, so you know me, I'm Judith Kluger, and so I'm going to just see if the mouse works a bit better. And we're going to talk about intrauterine contraception. So I've learned something new recently, and that is now the Faculty in Sexual and Reproductive Health calls it intrauterine contraception. And then they further divide it into copper IUDs and levonorgestrel IUDs. So you'll see me talk about IUC and also IUD. So let's start with the first case. And this, by the way, these are all real life cases except for one. And this case is actually one of my interns, and she gave me permission to use her scenario. So basically, she is a 32-year-old, well, she was 32 at the time. She was a mature student. I think she studied physio or something like that beforehand. And she had 2 previous cesarean sections. She was 11 months postpartum, but she was still breastfeeding. And because she was still a medical student, she only had hospital plan. And so she went to a GP at her local women's health clinic for her Mirena insertion. The GP advised her to insert misoprostol pervaginally the night before. And she said that during the insertion procedure, she experienced immense pain. And she felt like somebody had stabbed her suprapubically.
Sorry, Judy, can I insertion? She had to insert misoprostol the night before. Is the insertion procedure with the immense pain, that is the actual placement of the Mirena, is it?
Yes.
Or the misoprostol, the Mirena, okay.
The Mirena, sorry.
Okay.
So the actual insertion of the Mirena, she experienced immense pain and a feeling that somebody had stabbed her suprapubically. The GP had a small ultrasound machine. It sounded like a form of mobile ultrasound machine, and said that the Mirena was in place. She then proceeded to drive herself home, but said she actually struggled to drive herself home due to the pain and pulled off the N1 highway to catch her breath. So when she got home, she experienced abdominal distension. She was using maximum oral medication. Her brother and her father are doctors, and so she gave them a call, and they said, no, this doesn't sound right. Phone the GP again. So she phoned the GP, who reassured her that the Mirena was in the right place according to the ultrasound. And she then got the feeling that the GP was thinking she was overreacting. but booked her off for a couple of days for bed rest, which she did. But after a few days of bed rest, she still wasn't feeling well. So she did her own PV and she could not feel the strings. So she phoned the GP again, who declined to take her call. And the receptionist told her to go to the EC. But as she was a medical student, she was reluctant to go to the emergency center due to costs. And so she just decided she'll live with it. She didn't have any periods, but had this ongoing chronic abdominal pain, and for which she said she was on lots of pain medication. So now we have a single best answer question for everybody, and I think the case is missing strings or threads. So is it A, women should not be advised to feel their own strings, as this is not helpful and they can pull the IUC out? If they are missing strings, then the only two options to consider are perforation or expulsion. 18% of women will have missing strings, even if the IUC is placed with the standard interval IUC placement. In other words, they weren't recently pregnant, so not immediately postpartum or post-miscarriage. 80% of women will have missing strings if the IUC is placed at cesarean section. And the first thing one must do if there are missing strings on detection on speculum is do a pelvic X-ray. So while we continue, you can do the poll, and then I will give you the single best answer later. Karen, you must just tell me when the poll is done, and then we can give a report on the question, or on what everyone thought.
How long would you like me to leave the poll open for?
I'll give you,
we say 2-3 minutes?
Or another slide, and then we can close the poll.
Cool.
So, and this is what I wanted to, so do you think this medical student was overreacting? So, and this comes to another interesting point. I think this was a poll started by a patient in the UK who basically said that female pain is not taken seriously. It comes historically from us being hysterical. And remember, hysteria as a diagnosis was only removed in the 1960s, I think. And even at one stage, we had our uteri removed because that was the solution to all our hysteria. So this patient actually felt that the pain that she experienced with her IUD insertion was minimized, and she felt that was a reflection of how women's pain is not taken seriously. And so she started this poll, and it was in the BBC News. Coil pain, our voices have been heard. And as a result, the Faculty of Sexual and Reproductive Health actually issued a statement on pain relief for intrauterine devices. And what the conclusion is that pain with IUD insertion, the vast majority of women will experience mild to moderate pain. In other words, when asked to fill out a visual analog scale, either will score 1 to 3 out of 10 or 4 to 6 out of 10 being moderate. However, there will be a few women who experience severe pain. 7 to 10 out of that's how high they will score the pain scores. And even without analgesia, the majority of women will be okay. So who will experience pain? Well, the mean pain scores are higher in women who haven't had children before, who have previous cesarean section deliveries, and who have dysmenorrhea. So let's first go to the first thing, which was the use of misoprostol before the IUD insertion. And I know this was standard advice given by the Bayer reps, and it is in their pain relief options. I have got a leaflet from them. But one must remember that even though some studies report significantly reduced insertion pain with the use of misoprostol, others do not. So there is a Cochrane meta-analysis that showed that there are high mean scores for insertion compared with placebo with misoprostol. And then you think to yourself, how can this be? Well, misoprostol causes more cramping because it causes the uterus to contract. And so cramping was more likely. When looking at nulliparous patients, there were 2 trials that showed a high pain score with insertion and pain before leaving the clinic, and 1 trial showed lower pain scores and rated the insertion more favorably. And there was also more likely to have other systemic side effects like shivering, headache, or abdominal pain. So actually, the Faculty of Sexual and Reproductive Health don't even include misoprostol as an option in helping to minimize pain with insertion. So I think at this point, Karen, you can show our poll and we'll do the correct answer.
And there we go.
So the correct answer is 36% of you have answered, which is 18% of women will have missing strings if the IUC is placed, even when it is placed intervally. And I myself had missing strings with my Mirena, and I always thought to myself, yeah, it had to be because I'm a gynecologist. But luckily, my gynae, who I love, just simply removed it in the rooms under a paracervical block. No hysteroscopy required. So there is some debate about whether feeling your own strings. Some guidelines actually recommend feeling your own strings, and in the latest Faculty in Sexual and Reproductive Health, they don't even recommend the standard string check unless you had your intrauterine device placed postpartum, that being immediate postpartum within 48 hours. Okay. So missing strings is quite common. And if you were interested about cesarean section, it's about 50% placed at cesarean section, 30% if it's immediate postpartum, and 18% interval.
Sorry, can I come in over here, Judy?
Yeah.
Are you going to dwell on this? There's 2 questions have come up over here. Are you going to dwell on Mirena placement at cesarean section or not?
No. But we leave that till the end because I'm already worried I won't get to all my questions. But if we have time, we can discuss it. Because
it is off-label use. And the second question was, are you saying that we should not use misoprostol prior to insertion of intrauterine devices?
So here is my opinion. Misoprostol should not be used as routine, and you need to individualize each case and anticipate difficult insertion. As I mentioned before, the Faculty of Sexual and Reproductive Health does not even include misoprostol in their pain management measures, which I'm going to talk about next. So what do you need to consider? So oral analgesics, pre and post procedure. So prophylactic ibuprofen has not demonstrated to reduce pain scores during the insertion, but it has been shown to decrease the cramping experienced after insertion. Ketoprofen and naproxen taken in RB4 could be beneficial for insertion and post-insertion pain. So these are not drugs that we normally use, but this is what has been studied. Tramadol even has been shown to show lower mean overall pain scores prior to insertion, but the effect was greater with tramadol than with naproxen. Basically, non-steroidal anti-inflammatories are beneficial for treating established pain after insertion. So you should counsel the patient that you're giving this to really help with those cramps after the insertion, which makes sense because the uterus, what is anti-inflammatory? It's an anti-prostaglandin, and what stimulates uterine contractions are prostaglandins. So what they do.
So Judy, so I use Zephyr. What do you use? You said you don't use those things. What do you use prior to insertion of your loop?
I generally only use ibuprofen and paracetamol. However, what I do use commonly is a paracervical block. And this is actually recommended by the Faculty of Sexual and Reproductive Health. Here are pictures of, I don't think many people are aware, but there's a difference between a paracervical block and an intracervical block. The Faculty of Sexual and Reproductive Health actually recommends either. I use both depending on the reason for you doing the block. So why do I use a block? Because the biggest challenge with the narrowest part of the cervix is the internal os, and that's where you might have to exert a bit of pressure to dilate that part. And that part of the cervix is, most cervices are about 3 centimeters long. So if you inject intracervically, you really have to advance the needle up to the hilt, basically, to infiltrate the entire tract. And I think that's one of the reasons why people think the block doesn't work, is because I think you can't use a block which you'd use for a LETS procedure when you're doing a block for sort of dilatation procedures, or anything that dilates the cervix. Okay, what else does the Faculty of Sexual and Reproductive Health recommend? Well, you can use other forms of local anesthetic, 10% lidocaine spray. However, it must be applied 3 minutes prior to insertion. And I generally don't use this because I think it's bad enough having the speculum in. So imagine having to spray and then wait 3 minutes. Same argument with giving EMLA prior. You have to do that up to 7 minutes prior to the IUD insertion. And I think that just personally, my opinion is that just prolongs the whole experience. So if anything, I do a block.
So I've come in a little bit late, but I certainly agree with you. I think the blocks are one of the best things you can do, especially in nulliparous or patient who really aren't anticipating problems. If you can't get a dental syringe, it's actually very nice to use, because you kind of get a nice grip on it while you're holding your speculum, and it really just gets that needle into the right place.
And it's such a thin needle, Steve.
Yeah, I like using that.
Can I just ask you, the Faculty of Sexual and Reproductive Health, what faculty is that? What body is that? The Royal College?
That's a branch of the Royal College of Obs and Gynae, and they're basically a unit that constantly evaluates the literature with regard to family planning. And when you are in the UK, you actually have to get a diploma in family planning through this body before you can start giving contraception. And also bearing in mind, in the UK, it's GPs that provide the majority of contraception, not gynecologists. So there is a lot of online sources. I find it a very useful tool. You can now even do your master's in family planning and become a fellow in family planning through the Faculty of Sexual and Reproductive Health. So it's a branch of the Royal College.
And you're a fellow of the Royal College, are you not, Judy?
Yes, recently awarded. Thank you very much.
Congratulations. Well deserved.
Okay, thank you. So this I've basically screenshotted a lot of things from the FSRH guideline, and this basically is the key information, and they give the blocks and the local anesthetic as category C evidence. Also be aware of the patient, what can actually cause pain, the speculum, the tenaculum, the sounding, etc. And also they recommend actually having an assistant to give your verbal Verbicaine. So your assistant who provides reinsurance with the procedure. So now let's go back to our case. So a few months later, and remember this is a 5th-year medical student, she just let life happen. She eventually decided she's going to go and see her gynecologist to consult for her chronic pelvic pain. At the gynae consult, the Mirena was not in the uterus. On ultrasound, she subsequently had a CT scan, which showed the intrauterine device in the mesentery of the bowel. And at laparoscopy, the IUD was in the mesentery, quite close to a major mesenteric vessel. Interestingly enough, the patient had another Mirena inserted at the time of her laparoscopy when she had her perforated Mirena removal. So what the FSRH recommends, if you have a perforation, so if it's an immediate perforation, so for example, if you place it and you think, okay, you've perforated now, you must remove the device immediately, and not to place one until 6 weeks afterwards. But in this case, it was already a couple of months later, and so she had another one placed. So let's talk about perforation risk with intrauterine device insertion. So the overall rate of uterine perforation is usually very low, with the overall risk of perforation in the general population of about 1 to 2 per 1,000. Postpartum interval IUC insertion, that means within after 48 hours after childbirth. So when you talk about postpartum IUD insertion, you normally mean immediately within 48 hours, but that term also implies to postpartum up to, and I'll show you some studies, even up to 36 weeks postpartum, if not more. Those women have a higher risk of uterine perforation, especially if they are breastfeeding. Just interestingly of note, because I still, a lot of people sort of still think, why bother putting an intrauterine device at birth? There has been no recorded uterine perforation of an IUD placed within 48 hours of insertion, or IUD placed at cesarean section. So if you ask me, I would rather have an expulsion than a perforation. So I think this is the advantage of placing an IUD immediately postpartum within 48 hours, because number one, this might be the only time you see a doctor, especially in our public health sector, and have an opportunity. And number two, I don't want to send a woman out 6 weeks postpartum for the family planning nurse at the local clinic who maybe puts in one IUD every few months to put in that IUD. That IUD in the postpartum women after 48 hours or after is exceedingly high risk. So I think that's the case that I would rather have a specialist put in at that 6 weeks, that 6 weeks IUD. So what evidence do we have? Well, there's the URIS, which is a cohort study of more than 9,000 individuals. And what did they discover? Individuals who were less than 36 weeks postpartum and breastfeeding had a relative risk of 6.8 per 1,000 insertions. In other words, more than 6 times higher risk of a perforation than the baseline population. Individuals who were breastfeeding and gave birth more than 36 weeks prior to insertion were still high risk, and that is relative risk of 5.1. So remember, in this case, this woman, this medical student, I think, was 11 months postpartum, but she was still breastfeeding. So she was the highest risk of perforation. Individuals less than 36 weeks not breastfeeding, the relative risk was 3. And individuals not breastfeeding and more than 36 weeks postpartum, the relative risk was 1.2. In other words, now we're starting up to 36 weeks postpartum. Now we're starting to return to the baseline population. Okay, so that I hope you could all appreciate. Your highest perforation risk is the postpartum breastfeeding woman, and this risk extends to even after 36 weeks, even if breastfeeding. So now we're going to do case 2. By the way, I know I often talk more than I should, so I have 4 cases, so please stop me when you feel like I'm long in the tooth. So this is case 2. So Mrs. Here comes your next poll. Okay, so I'm just going to minimize the poll. So Mrs. Macy is a 45-year-old, gravida 2, para 2. You insert a Mirena for contraception. Her BMI is 35, well-controlled diabetic. Her HbA1c is 6.2%. And you give her the Mirena card, which says it's registered for 5 years, but she says, I've heard you can use the Mirena for longer than 5 years. What do you recommend? So our options are, and that was the poll, do you remove and replace after 5 years of use? Do you remove and replace after 6 years of use? Do you remove and replace after 8 years of use? Do you remove after 8 years, as will be 53 and postmenopausal, so she doesn't really need anything? Or do you remove after 10 years use, as will be 55 years and definitely postmenopausal? So let me just see what my next slide is. So Karen, actually, so I'll tell you when we'll get to the answers. So now all of you are confused, right? So why are you confused? Well, we know that if you look at the Mirena website based in the US, so mirenaus.com, here it says now approved for up to 8 years of pregnancy prevention. And this is based on one of the studies is the Mirena extension trial, and this is where the Mirena was used up to 8 years. However, there are quite few numbers, and if you look here, there was, I think, the cumulative there were pregnancies. I think 3 pregnancies in total from years 6, 7, and 8. And then if you look at this slide, you'll see the Pearl Index per 100 women years of use. And then it's surprisingly, or not surprisingly, because it has the best Pearl Index at year 8. But this is just an example of the flaws of the Pearl Index, is because as women fall pregnant, they leave the cohort. And so that's why if you look at Pearl indices, you actually have to appreciate what population you're studying and how long you're studying, and also the numbers. Good. So what about, so I'm just leaving it there for some thought. But now, what does the Faculty of Sexual and Reproductive Health say? Because you know me, I'm very UK-based, not very American-based. So the FSRH, and they updated this guideline in July 2023, says any 52 milligram levonorgestrel IUD at the age of, by the way, close the poll if you haven't closed it yet, because I think I might be giving you the answers now.
Okay, we'll do.
Any 52 milligram levonorgestrel IUD inserted at age less than 45 years can be used for contraception for 6 years. So they contradict the US website. So just remember that's FDA approved for 8 years, but I haven't actually looked to see what their society recommends. They themselves also have a Society of Family Planning. The Faculty of, and this is based on the fact that in the UK, they've got different 52 milligrams levonorgestrel IUD. So the Mirena is registered for 5 years in the UK, but Levocert and Benelexa, which are 2 generic forms of that, are actually licensed for 6 years. And hence, their recommendation is based on the fact what is actually licensed for use. What they do also recommend is that if you place the Mirena or the IUD after 45, you can leave it in up until 55 years of age. And if you're using a copper IUD, as long as it's got a minimum of 300 millimeter squares of copper, you can, if it's placed after 40 years, you can basically leave it in until you are sure menopause has occurred. So the correct answer, and I'm going to tell you why in the next slide, is the last one, which is remove after 10 years use, as will be 55 years and postmenopausal. So basically what oh, sorry, I didn't actually put that. I think it's maybe in the next slide. Basically what they're saying, because your fertility is declining after 45, And because you actually need to use contraception till you're 55, if you're interested, there's a guideline for that, when to stop contraception. And because the 95th centile for menopause is 55 years of age, they actually recommend using a contraceptive till 55. So if you remove the Mirena at any time beforehand, you need to replace it. However, they say if you put it in after 45, you can actually leave it in until 55. On the proviso, it is only for contraceptive use, which gives me to the next caveat of our case. Mrs. Macy is now 48 years old. She's had a Mirena in situ for 3 years. She's mostly amenorrheic, some spotting every few months. However, she's complaining of hot flushes, vaginal dryness, and discomfort during sex. You decide she needs a little bit of estrogen, so you start her on Femigel, which is a 17-beta estradiol. So now would your recommendation, so now we're going to get to the next poll, and because you are now giving her estrogen, how does your recommendations change, if at all? So can we run the poll again, please, Karen?
Can you see it all working?
Okay, so I'll give you a few moments to complete that, because my next slide is the answer. Okay, I think that should be enough time, Karen. Let's see what the answers show. So the correct answer is actually, because you're now giving her hormone replacement therapy or hormone therapy, it changes. The recommendations now change. The answer is A, remove and replace after 5 years of use. So why is that? Because even if you look at the US and the Bayer websites, they say it might be 8 years for contraception, but it is still 5 years for endometrial protection for HRT, and it is still 5 years if you're using it for heavy menstrual bleeding, particularly. So the FSRH guideline is any 52 milligram levonorgestrel IUD can be used for 5 years as endometrial protection as part of a hormone replacement therapy. Because remember, you are now throwing some fertilizer, and the question is your Mirena after 5 years a strong enough lawnmower to keep your balance in your endometrium, to prevent the endometrial proliferation that your estrogen might be doing? Okay, so now we can go to our next case, and this is a real case. Back in 2021 in PAL, the GPs and the local doctors all have to phone you if they want to refer patients to you. They can't just make an appointment. We also now do it on the Vula app. So almost all gynae patients are consulted with us telephonically before they get an appointment, so we can triage them. So basically a GP from Azafontein, and Azafontein doesn't usually drain to PAL, phones PAL for a gynae appointment. I accepted the referral because I thought, oh, this sounds interesting. And she's a 50-year-old, gravida 3, para 1, M1, T1, who complains of recurrent vaginal discharge every couple of months. She gets associated abdominal pain, back pain, especially left eyelid pain, with some relief when the discharge starts draining through her vagina. She gives a history of having had a copper IUD placed a couple of years ago. Now, the GP says she did a speculum, and she's not quite sure what she's seeing, but she thinks she sees a hole or a sinus in the posterior fornix, and it is draining pus. So then I see her. She gives me a past history that in 2019, she was admitted to another secondary level hospital with PID, where she was treated for 4 days. I could access the NHLS blood results, and I could see at the time when she was admitted, her CRP was 362, her white cell count was 21, syphilis negative, HIV negative. Interestingly enough, there's also a CA125 of 37, which means to me that there must have been some form of ovarian mass, which prompted the doctor to do a CA125, even though the woman is not postmenopausal. However, she sort of, because she's from rural areas, sort of lost to follow-up and presents in 2020 again, admitted to, again, the same hospital, now with a diagnosis of grade 3 up PID, and I could get that because with a little history of the pap smear, I could see somebody wrote their grade 3 PID. Pap smear shows it's normal, but there were no endocervical cells. This time, her white cell count is 22, platelets 898, CRP is 139. I actually phoned the patient again today just to get the full story. Again, all her side of events, because I'm on holiday at the moment, so I don't have a file. So she said that the doctors didn't discuss her copper IUD with her, so she just left it at that. But she thought when she saw me, she thinks she can feel the stem of the device in the cervix. So on the gynae exam, we see the IUD. I can see the stem seen at the cervix. I can't remember if I saw any strings, but yes, there was a draining sinus in the left posterior fornix. On ultrasound scan, the appearance was that the intrauterine device was in the cervix, and I got the impression that the arm was actually perforated through the cervix into the left. I could also see a left tubo-ovarian complex mass. At the time, I treated her with syndromic management. I repeated the pap smear, and I removed the copper IUD and placed it in saline for culture. This is not the patient, however, but I found this picture in my archive to show you. I know it's not a very good picture, but this actually shows how this is a partial expulsion of a copper IUD, with it not coming out through the os at all, and the arm has perforated. So I think, if I can remember correctly, the IUD was actually in the cervix, but the arm was perforated through the cervix. And this is also not her ultrasound, but I found this ultrasound showing that you can clearly see the IUD is sitting in the cervix. And in this case, they actually did a 3D ultrasound, which is the picture B, where they showing you how the arms have perforated the muscle of the uterus. So her IUD culture shows no bacterial culture, and her pap smear comes back as negative for any malignancy. Endocervical cell component is present. However, bacteria is morphologically consistent with Actinomyces species. So, in my opinion, I think the reason why she kept on representing is that she wasn't having pelvic inflammatory disease due to a STI or gonorrhea. By the way, I didn't put that in. She actually had a vaginal swab at one of her PID presentations, which showed gonorrhea negative, trichomonas negative. I think this was one of those, this is the first case in my career where I actually think that her symptoms was due to actinomycetes organism. So what does the FSRH recommend about women who present with pelvic inflammatory disease? So I'm moving away from actinomycetes. So don't get me wrong, you mustn't think everybody has got actinomyces like organisms after this presentation. What are the recommendations about somebody presenting with PID who has an IUD in situ? Well, if you have mild to moderate PID with the IUC in situ, whose clinical condition is improving over the first 48 to 72 hours, then you can leave the intrauterine device. You do not need to remove it. However, if the clinical condition does not improve after 48 to 72 hours of antibiotics, remove the IUC. If there has been unprotected vaginal sex, so this is also another thing that people don't realize, that when you remove the intrauterine device, you're essentially making this woman immediately fertile. And the emergency contraceptive recommendations apply, because if you switch to a hormonal method, they actually can fall pregnant before the hormonal method kicks in. So if there's been unprotected vaginal sex within the preceding 7 days, EC and follow-up pregnancy testing should be considered. So I think in this case, because I know in 2019, she was in hospital for 4 days, and then because I can see when they had blood tests, and then the second case, she actually had, I think she was in hospital for about a week. The fact that there was a tuber-ovarian complex, so I'm not quite sure if they forgot about the IUD, but I would have seriously considered maybe removing the IUD at the second presentation, especially because she was almost 50 at the time, and etc. So pelvic actinomycosis is a very rare chronic bacterial pelvic infection that is associated with long-term IUC use. Now, you'll often find that it's a normal commensal, and if you do routine pap smears every year, you will find that it colonizes the intrauterine device. I think it increases exponentially. I think after a year, it's 1%, then it goes up, etc. So, of course, in the state where you're doing a pap smear every 10 years, you're not necessarily going to find this, but if you have actinomyces organisms, if they don't have any symptoms, you can actually leave the IUD in, or the other recommendation, but you need to follow them up, or the other recommendation is just to remove and replace. You don't have to give antibiotics for everyone who's got actinomyces-like organisms found on the pap smear. So what happened? Another thing that I wanted to just add, because I get asked this very often, what do you do about a malpositioned or a displaced IUC? Well, there's published evidence is too limited to predict failure rates of malpositioned IUC, because I often get asked, well, at what point do you remove and replace? But the faculty says it's a good practice point, which means it's basically expert opinion, no good evidence. General guide is to just suggest remove and replace in the following conditions: if the IUC is more than 2 centimeters from the fundus, if the IUC is within the cervical canal fully or partially, or if the IUC user is experiencing symptoms that may be related to a malpositioned IUC, like pain or bleeding. So you don't have to remove and replace every single IUC that doesn't appear exactly inside the uterus. And I think this especially goes for the Mirena. Even if I see the Mirena sitting just above the cervix or partially in the endocervix, I don't automatically remove and replace it unless the patient is giving me some form of symptoms. Okay, next, so what happened to this lady? So we treated her with amoxicillin for 1 month, and this is also where I actually had to go and review the literature, because some people talk about 6 months of amoxicillin use, but we decided just to use 1 month. And sort of halfway through her treatment, she sent me a little WhatsApp, which said, "Verskriklik baie dankie, Dr. Kluge, my heldin, ek voel soveel beter, pyn en liefde is weg." We then saw her 10 months later, back in 2022, and her tuber ovarian mass was reduced with no more pain or vaginal discharge. So that's the end of the case. I have one more case. I just wanted to just have a checkup on my time. Do I have enough time to do?
Yeah, we absolutely, yeah. And we've lost Pete here to go and do a ruptured ectopic.
Okay, sure.
Yeah, but yeah, absolutely. I'm sure it's been very interesting so far, and
okay, because
what about
so
6
this
run through at the end? But yeah, I think let's do this last case quickly, and then we can answer the
okay,
question.
sure. So this is not a very long case. And I must thank Ilana Johnson for this case. She's been nagging at me to look at the literature. So I finally have decided to relent and look at it. So it was a 31-year-old nulliparous patient with a very stressful job. She came to see the gynae after 5 years of use. She gives a history that she had it previously, the Mirena inserted in 2017 for severe dysmenorrhea with another gynecologist. And 8 months after the insertion, she experienced total alopecia. That means the patient went bald, even losing eyebrows and eyelashes. The patient thought to herself, maybe this is linked, but decided her dysmenorrhea is so much better, she is just going to continue. Of note, she still had pubic hair and armpit hair. She did give a history that when she was 22 years old, she only ever used hormones before, when she had to take the emergency contraception, and then she experienced a patchy alopecia, which then resolved. She has a background history of major depressive disorder and general anxiety disorder. She was on Wellbutrin, which was changed to venlafaxine in 2018, which didn't make any difference to her alopecia. And she came to the gynae to remove the Mirena in June 2022, who thought, well, let's try a non-hormonal method. The patient said her dysmenorrhea had significantly improved, and her hair started to regrow in October. Now, the question is, was this because she was no longer in a very stressful job? She was on sabbatical, but basically in July 2023, almost just over a year after her Mirena is removed, she now has a full head of hair, but her eyebrows and eyelashes are returning. So now is the question, did the Mirena cause the alopecia? So thank you to Bayer for providing me with last-minute literature review. Nulo et al. Did a survey-based study of only 206 patients in which 51 women responded, and 76% of the respondents reported no change in hair loss. However, 20% of women reported worsened hair loss and had improved hair loss after the levonorgestrel IUD placed. The authors then concluded that there wasn't really a significant association with alopecia, but the numbers were very small. Now we look at Patterson et al., who actually just looked at the adverse events reporting and looked at the database. So this was retrospectively. So the two databases that they looked at was the New Zealand Intensive Medicines Monitoring Program, where alopecia was recorded in 5 cases of 1,670 IUD users. So that's basically 0.3% of the levonorgestrel IUD users had alopecia. 4 out of the 5 cases occurred within 10 months after the IUD was inserted. And in 3 cases, the levonorgestrel IUD was removed. And in 2 out of those 3 cases, the woman reported to have recovered from hair loss after the removal. Looking at the World Health Organization database, I can't give you how many numbers there are, but these were 68 cases were reported to the WHO. 34 reports had sufficient evidence for causality assessment. So basically there were 68 cases of alopecia, but they thought only 34, there was enough evidence to actually look at the cause. 23 of the 34 reports that levonorgestrel IUD was the sole suspect medicine. 10 reports included other systemic adverse reactions, and the levonorgestrel IUD was reportedly removed in 14 out of these 34 cases, with a positive D challenge in 3 cases. In other words, there was a recovery of hair loss, recovery from the hair loss after removal, indicating a probable causality. 5 women had not yet recovered, and 6 women had an unknown outcome. So the basis of this, Patterson et al. Just felt that you need to recommend, you need to report it to women that it might be, but it's exceedingly rare association at present. Then look at Backman et al. And they looked at a survey of 15,000, almost 16,000 users. And out of those users, 15.7% reported some loss of hair. So not necessarily alopecia, but losing some hair. And the risk ratio for premature removal of the levonorgestrel IUS due to this hair loss was 0.71. And in my Google search, I found this advert that says effective tips for reversing Mirena-related hair loss. And then we come to the last slide, which is why would alopecia or hair loss occur? So the first possibility is that levonorgestrel is an androgenic progestogen. So if you look at this slide, this was the hair loss before the Mirena was removed, and the following slide is after. And you can see this is definitely a sort of male pattern baldness. So isn't it got a fact to the androgenic effect is one postulation. The other postulation is telegium effluvium, which, if you're a dermatologist, is a condition where more than 30% of the hair follicles are in the telogen or resting phase. So normally your hair goes through different cycles, and about 8 to 10% of your hair follicles are in the telogen phase, which is basically it's resting. And when it's resting, you normally lose the old hair, and then it takes a while for the new hair to come in. And so this has been mentioned that this can occur with any major hormonal event. So the postulation is this not maybe a shock effect of the levonorgestrel on the hair follicles, which causes this more than usual effect of the hair follicle to go into the telogen? And then on one website, it stated that Bayer states 1% of patients experience some form of hair loss. So I'd be interested what the Bayer who's online would like to comment about that. But those are my cases. I hope you found it interesting and something unusual and not your everyday IUC case studies.
Thanks so much, Judy. That was very interesting. And as you note, the placement and the use of Mirena is very common and often very easy. But when one does run into trouble with it, it can be quite tricky. And it's sometimes not the most straightforward device to manage afterwards. So thanks so much. It was really a wonderful session, and just the practicality and the clinical aspects were very nice to discuss. We do have some questions. We'll try and run through them quite quickly. Is there a better part of the menstrual cycle where insertion is easier?
I know this is so I know this has been recommended to put it in when you're having your menses. However, I remember reading one I think population study that found that your expulsion risk is higher when you're putting in the IUD at the heavy part of your cycle. So I get that often, like, you need to come in when you're menstruating, and even patients said, I'll come when I'm menstruating. And I'm like, actually, no, I don't want to put it in when you're on your heaviest part of your cycle, because what's actually happening when you're menstruating, your uterus is contracting. And there is evidence to show that's not the best time to put it in. Maybe day 4 or 5 of the cycle. Also bear in mind that where did that recommendation also come from? And that comes from you being reasonably sure the woman is not pregnant, which but there are quick start questions that you need to ask. For example, have you had sex since your last menses? Are you using another method? So basically, you can put in an intrauterine device any time of the menstrual cycle, as long as you're reasonably sure they're not pregnant. And that's a whole nother set of questions that you need to answer in your consult. Excellent.
Just a few other quick questions, because it is now nearly 6 o'clock. Another comment really is, why is it called perforation, not migration? and when does the perforation actually happen? Is it not painful and symptomatic? But I mean, I would always assume that if it's in the wrong place, you've normally basically put it into the wrong place. I don't think it pops out by itself. Is that your sort of feeling about it as well?
Migration, I think, is a misnomer because it gives this impression that if you, the same with the implant, if you put it in perfectly, it still pop out like, you know, like randomly go through your uterus whenever it feels like, and then just travel around your whole body. The majority of perforations occur, and I think perforations is the better term. I don't like the word migration because I think it gives women misperceptions, is actually with the insertion procedure. So it's more the provider perforating the uterus than the IUD just randomly perforating the uterus. So there is a little bit of opinion with regards to secondary perforation. That means the uterus, it was placed normally to start off with, and then it perforates later. That's a whole nother debate in itself. And that's also one of the arguments is also the shape of the uterus that was the problem. Maybe it was a malposition, and then when you had a menstrual cycle, the uterus contracted. Bear in mind, your uterus is a powerful muscle. But I think the message should be that perforations occur with insertion. And I went to a Bayer conference a few years ago in Germany, and the German clinicians, they actually use their ultrasound while putting it in. And I do that as well. If I am anticipating a difficult procedure, I get one of my medical officers to hold the ultrasound machine, and under ultrasound guidance, I put it in. I don't use the ultrasound to check it in afterwards. I actually know exactly where I am every second I'm in that uterus. And most women, I think, will experience maybe some form of discomfort.
Right. All right, thanks. And that does answer then one of the other questions. And then one of the last questions is what antibiotic do you treat actinomyces with?
Amoxicillin.
Okay, perfect.
Whether you give 1 month or 6 months, it's the literature differs. My patient improved after 1 month. So most guidelines say 1 month.
Excellent. All right. Well, thanks so much. We have come to the end of the session. It's been really fantastic. Thanks for the session. Thanks for the way in which it was presented. Thanks to Bayer for their kind sponsorship. Just as a reminder, we won't have any webinars for the next 2 weeks. So we look forward to seeing you all again after we've had a little break. But thanks again to Julia. That was really fantastic. Thanks for your time. Thanks for your effort, for the detail in which you presented those. And looking forward to seeing you all quite soon, and enjoy the holidays if anyone is going on holiday. Thanks so much.